I'd now like to talk a little about sperm retrieval and the techniques at the CRGH. Of course, there are different techniques of sperm retrieval, and this is all in conjunction with an IVF and ICSI cycle. So if a man is azoospermic, in other words, no sperm in the ejaculate, then it's the urologist's job to harvest sperm for the IVF cycle. Now, if there's an obstruction for whatever cause, patients that have had a vasectomy in the past, maybe they've had a sexually transmitted disease causing an obstruction, then the operation is a needle aspiration of the epididymis. This procedure is called PESA, percutaneous epididymal sperm aspiration. It's done under a local anaesthetic. It takes about 10 to 15 minutes to perform, and it's usually done on just one side of one testicle. If a patient is deemed not to have an obstruction, and this is usually by a clinical examination, the patients have smallish testes, they do not produce sperm in the ejaculate, and their hormone levels, particularly the FSH level, is high, then they're deemed to have non-obstructive azoospermia, and you therefore have to get tissue from the testicle itself. There are different ways of doing this. You can put a needle straight into the testicle in different areas. That's known as TSA, so testicular sperm aspiration. But the conventional operation is a microdissection testicular sperm extraction, known as micro-TZ. This usually involves one, sometimes both testicles. You have an embryologist in the lab with you, and you are in effect dissecting the testicle out under a microscope, looking for areas within the testicle that are likely to produce sperm. So these are tubules which are slightly distended, and we look for these tubules in the hope that then when we give them to the embryologist, they'll be able to recover sperm. Now, the recovery rate of sperm varies from patient to patient. So, for example, in patients that have had previous TZs, then the results are going to be lower. Patients with genetic abnormalities, for example, Klinefelter syndrome, their results may also be lower. So it does vary, but at the end of the day, everyone has a chance, and so usually everyone then goes with the operation. Results can vary. So, for example, I may give them a prognosis of 10 to 15% in some situations. Otherwise, in other cases, the prognosis may be 50 to 60%, because there's different parameters to establish, what are the prognostic factors, what are the likelihood that we're going to be successful in retrieving sperm. Now, if I'm really optimistic and say I'm going to find sperm on this patient, then we will give the couple the opportunity to have a fresh IVF cycle. In other words, the eggs are collected on the same day as the male has the sperm retrieval. The opposite is true, is if I'm a little bit skeptical, or the IVF team is skeptical that this is going to be difficult to find sperm, they would rather not put the female partner through an IVF and ICSI cycle, and then for me to say I was unable to find any sperm when all the eggs have been retrieved and then have to be frozen. So in that situation, we tend to do the micro-TZ in isolation. So it's just the male and myself. We organize the operation, and then if we find sperm, we freeze the sperm, and then the female partner can then undergo an IVF cycle and use the thawed sperm that we've retrieved. So that is an option. There is, of course, a donor sperm option. So if the couple are happy to have a donor sperm as a backup, then we would always do it as a fresh cycle. So in other words, the female has an IVF and ICSI cycle. Her partner has the micro-TZ. If we're successful in retrieving sperm, excellent, we'll use his sperm. But if not, the eggs will not be frozen. The eggs will be used and inseminated with donor sperm. The operation itself takes usually about 1 to 1.5 hours. It's always a day case procedure. Patients usually need to take 3 or 4 days off work. So although it's technically demanding using the microscopes, it's all fairly minor surgery from the patient's perspective, in that they have a small wound on the scrotum which heals without a scar. They have a little bit of swelling and bruising, but usually they recover very quickly. So there has been recent data to suggest that we could improve our success rates of sperm retrieval by stimulating the patient's hormones for a period of 3 to 6 months prior to the operation. We tend to use a combination of menopur and clomiphene, and we would give this for 3 to 6 months prior to the operation in those patients that I think that the prognosis is likely to be quite low, and so we're just trying to increase the chances of a positive sperm retrieval 3 to 6 months later. Not all patients want to do this, and if I'm pretty optimistic that I'm going to find sperm, then I wouldn't bother with stimulating them beforehand. But if I know it's going to be very difficult, perhaps they have a microdeletion, some genetic abnormalities, we may want to do some stimulation first.